the virtual meeting on recent advances in the management of lung carcinoma. So let us begin with the program. To deliver the first talk, I would like to invite Dr. Pradeep Chandrakar. He's professor in the Department of Radiation Oncology from Regional Cancer Center, Raipur, and he's going to speak on paradigm shift in the management of NSCLC and introduction. Thank you, and over to you, sir.
Should I start?
Yes, sir. So you can.
Sir is coming, ma'am. Sir is coming to inaugurate the program.
Okay.
Let's sir should initiate the program, ma'am.
Okay, sir.
Yeah. Ma'am, can I share slide from my own side so that I can scroll my slides?
Yes, sir. You
Yeah.
can share your slides.
Just allow me.
Yeah. You can share.
Yes.
those days, uh, they come with huge mass in both sides of the because of smoking. Smoking has uh, very popular at that time. So it was a disease of uh, male because very small amount of females they were smoking at that time and the advent of knowledge now people they have stopped smoking. That's why the incidence of commercial customer has gone down. Uh, and earlier days was the number one mortality, mortality is in West and two for India also. Now, another uh, variety of lung carcinoma that I know is rising now because because most probable reason is environmental pollution, air pollution, water pollution, and all sorts of pollution. Active smoking, passive smoking, second hand smoking. Uh, the main reason of adenocarcinoma. Now, adenocarcinoma will most commonly occurs in non-smokers. Now, this adenocarcinoma is rising in females of females and young children of as well as male population also. So, to this, there are four fact topics on which my colleagues they are going to give some text information how to manage. Uh, I think the present adenocarcinoma and squamous cell carcinoma as well. So, this first, Dr. Lee, also uh, my first speaker. Uh,
Paradigm shift in the management of lung cancer.
so I'll invite Mr. Doctor for this topic. Please.
Thank you so much, sir, for your nice words and introduction to the lung cancer. Now we go ahead with the topic. Today's topic is the paradigm shift in the management of the non-small cell lung cancer. Uh, as we all know, now lung cancer is becoming as a most common cancer, just followed by the breast cancer and lip oral cavity cancer and cervical cancers. And uh, we know mortality wise also it is a fourth most common cancer. Uh, Among the all the cancers, the adenocarcinoma that is non-small cell lung cancers, they accounts for more than 85% of the lung cancers. And among these, squamous cell carcinoma and adenocarcinoma both are the part, and among them, especially in the non-smokers, adenocarcinoma is emerging as a new most common histopathology. Many biomarkers are expressed in the lung, and they are now making us a new target uh, treat these cancers, and it is changing the scenario of how we treat the lung cancers. Biomarker testing has been So biomarker testing has make difference in the treatment decisions for patients with advanced non-small cancer in nearly 10 years, and now becoming increasingly relevant for the early stage non-small cancer as well. In advanced disease, the use of targeted treatment for the patients selected on the basis of biomarker testing has revolutionized the management of advanced non-small cell lung cancer. Several agencies, including ASCO, NCCN, ESMO, CAPE, ISC, LMP, has developed evidence-based guidelines to inform targeted therapy selection for these kind of patients. Even in the early stage lung cancers, with the approval of osimertinib for early stage non-small lung cancers, guidelines now recommends biomarker testing for all the non-small cell lung cancer, especially for the EGFR mutation in this setting. Rate of disease recurrence following curative intent surgery remains very high, and new options for the adjuvant therapy could help to improve patients' outcome. Evidence now supports the introduction of molecular testing in the adjuvant setting for patients with the resected stage, is starting from the stage 1B to stage 3 ADCs. So most of the guidelines, either you see the ASCO or NCCN or ESMO guidelines, all they recommend testing of few biomarkers which are nowadays very essential for treating any of the non-small cell lung cancer. These includes EGFR mutation, ALK rearrangements, ROS1 rearrangements, PDL1 expression, BRAF mutation, NTRK gene mutations, MET and exon 14 skipping, and RET rearrangement and KRAS mutations. There are so many X-enable biomarkers in the lung cancers, and many biomarkers are also available which are non-X-enable, but still search is going on for some specific targeted agents that can act on these biomarkers. The X-enable biomarkers in the non-small cell lung cancer, especially in the adenocarcinomas, are EGFR, LK, ROS1, KRAS mutations, BRAF1, RET, NTRK, and MET. And especially though in those where targets are not available, PDL1 expression is an important marker, and HER2 mutation. When we see the 5-year overall survival rate in all stages, in stage 1 it goes up to more than 90%, whereas in stage 2 it was almost 60 to 65%. But in locally advanced cases, the survival was almost 25 to 40%, and in stage 4 it is less than 10%. But with the availability of the new biomarkers, this was enhanced. How we stage lung cancer? So we can use non-invasive techniques and invasive techniques. Among the non-invasive techniques are, we can use CT, PET-CT, MRI brain, and among the invasive techniques, there are non-surgical modes like endoscopic ultrasound, endobronchial ultrasound, and surgical intervention like mediastinoscopy and beds can be used. Why do we use invasive staging in the case of lung cancers? Because there are studies which says accuracy of the CT and PET staging in medicinal lymph node from 43 CT and 45 PET trials. The sensitivity of CT is almost 55%, whereas PET CT goes up to 80%, and specificity is somewhere between 80 to 90%. But when we see the invasive technique like mediastinoscopy, uh, endoscopic ultrasound, endobronchial ultrasound, the specificity goes up to up to 100%. So most of the cases are diagnosed, and sensitivity ranges from 80 to 90%. Among the overview of the what treatment we can offer to the patient, stage wise is in stage 1 surgery is offered, and it is a treatment of choice, and radiation is used in the inoperable cases. In the case of stage 2, we can offer surgery followed by adjuvant chemotherapy, and in stage 3 up to 3A we can offer surgery, but beyond 3A, and in those cases, even in the stage 3A operable cases, suppose some contraindications are there, either patient is having a patient is old or some comorbidities are there, we can offer concurrent chemoradiation followed by consolidation immunotherapy. In stage 4 or recurrent disease, targeted therapy, immunotherapy, and chemotherapy and supportive care is the main option. So outcome of the early stage lung cancers needs to be improved. surgery is the primary treatment of these patients, and adjuvant cisplatin-based chemotherapy is recommended in all cases beyond stage 2 to 3A, and in selected stage 1B. Results from the large randomized trial and meta-analysis showed that 5-year overall survival benefit with the adjuvant chemotherapy in patients with the early stage lung cancer. And what we have seen with the various trials, the overall disease recurrence and the death following surgery without adjuvant therapy is very high. In case of stage 1B, it goes up to 45%. But in case of stage 3, it goes beyond 76%. There are the studies which says adjuvant osimertinib improves the disease-free survival in resected EGFR non-small cell lung cancer, and disease-free survival in overall all cases. There is a 73% reduction in the risk of disease recurrence or death with the osimertinib. Whereas when it is compared for the in updated result for stage 2 and stage 3 disease, it goes there is a 77% reduction in the risk of disease recurrence or death with the osimertinib. Adjuvant osimertinib improves disease-free survival in the resected EGFR mutated non-small cell lung cancer, and the results, the reduction in the risk goes more than 77%. For the management of the unresectable locally advanced non-small cell cancers, especially when mediastinal lymph node involvement is there, always it is considered as a stage 3 disease. Stage 3A diseases are those which are very small tumors, but there is a involvement of the Scanley node. There are the tumors which are more than 5 to 7 centimeter, but there is an involvement of the Hylan nodes. There are the tumors which are T4, that is more than 7 centimeter, but there is a no node involvement, are considered as a stage 3 A tumors, and they are borderline operable tumors. Stage 3B tumors includes stage T3 and T4 tumors with involvement of either carinal nodes or mediastinal nodes. Are very small tumors with the involvement of the Scanley nodes are considered as stage 3B, and these are inoperable tumors. And stage 3C includes the large T3 lesions or T4 lesions with the involvement of the Scanley nodes. So treatment for early stage cancers, the surgical options includes lobectomy. It is the standard approach, and pneumonectomy is offered in the case of where the disease is close to the hilum or proximal tumors to large airway tracts. Waist resection and segmentectomy is used only in those patients with low pulmonary reserve. So lobectomy is the treatment of choice in most of the cases. Among the CTRT, this is the standard of care now, especially in the locally advanced cancers, and concurrent chemoradiation does better than the sequential chemoradiation. We compare the data in early stage 3 cancers. Surgery gives the best results where it is operable in stage 3A, but in other cases, only concurrent chemoradiation does better than the sequential chemotherapy. Outcome from the other studies for the consolidation chemotherapy post primary therapy, either surgery or concurrent chemoradiation, the results have shown no benefit. So consolidation chemotherapy or after radiotherapy or post CTRT have demonstrated no benefit in any of the cases. Coming to the Pacific study design, where it is a phase 3 randomized double-blind placebo-controlled multi-center international trial, where patient with the stage 3 locally advanced unresectable non-small cell lung cancers who have not progressed followed by concurrent chemoradiation. Drug durvalumab is given every 2 weekly for next 12 months, 10 milligram per kg IV every 2 weekly. The primary endpoint for this study is progression-free survival and overall survival. And secondary endpoint are overall survival rate, or duration of the response rate, or patient-reported outcomes. It is compared with the placebo. And the results are of this study is very good. All patients received 2 or more overlapping cycles of platinum-based chemotherapy or concurrent chemotherapy before starting these drugs. And most patients had received concurrent chemotherapy in most of the cases, more than 99.7%. The updated 5-year overall survival rate shows there is a definite benefit in the overall survival. It is almost 47.5% in the durvalumab arm as compared to the placebo arm. So first and the only approved immunotherapy to demonstrate 42.9% overall survival at the 5 years. Updated 5-year progression-free survival with the durvalumab says that median overall survival benefit of 16.9 months as compared to only 5.6 months in the case of placebo. So in the Pacific study, when subgroup analysis is done, including the different stages, including the histopathology reports and the PDL1 positivity, in all cases, when you see the graph, all the graphs goes towards the left side. That means durvalumab shows a better results as compared to the placebo. How we manage the metastatic cancers. We see in the lung cancer majority, more than 50% of the lung cancer patients are diagnosed in stage 4, and treatment goal in this case is to extend the survival, maintain the and improve the quality of life, and relieve the severe and the debilitating symptoms, and limiting the adverse events. Here, current metastatic case, chemotherapy is the primary option. Here we give histologic subtyping for the chemotherapy, and whenever there is some target, we can address the targeted therapy for the genomic driving like EGFR, ALK, or ROS can be used. And in those cases where these targets are negative, we can see for the PDL1 high scores, and if it is high, then we can offer immunotherapy. So, with the aid of targeted therapy, immunotherapy, survival has enhanced in the FLORA trial, where we have added osimertinib. The survival has gone, 12 months survival has gone to, overall survival is 38.6 months. Whereas in keynote study for the PDL1, where it has gone more than 50%. So now we can offer different lines of targeted therapy as per the structural distinction. In the first line, we can use gefitinib and erlotinib. In second line, we can offer efatinib and decamtinib. And in third line, we can offer osimertinib. When we compare the relative maximal inhibitory concentration, we see that osimertinib is active in most of the cases for the inhibition of all the mutations, especially for the TD790 mutations. And other drugs, they have little activity. So when there is a comparison, head-to-head comparison with the various targeted therapy available, when we compare, when we see the effect of gefitinib, the survival benefit is overall survival response rate is 71% compared to the chemotherapy only. For erlotinib, it goes to 64 to 83%. And when different TKIs are compared, so in case of efatinib, as compared to other, this survival is 11.1 month, whereas as compared to the gefitinib, where survival is only 11 months, the overall survival goes to 10.9 months in efatinib, and median overall survival is 70.9 months in the efatinib and 24.5 months in case of gefitinib. Whereas in Archer trial, we see when decamtinib is compared with the gefitinib, the overall survival goes to 34.1 months versus 26.8 months in the decamtinib. Maximum survival is seen in the osimertinib, where in FLORA trial, where it is compared with the standard TKI, where survival goes beyond 36.8 months versus 32.6 months in the other arm, and it is statistically very significant. When we see the curve in the survival, when the response to the therapy has started in all the metastatic cases with the stable brain mets, we can see in the efatinib arm, the graph is moving towards right after 12 months, whereas in the decamtinib, it moves is starting moving after 6 months. But we can see there is an immediate separation seen in the osimertinib arm, which is starting the therapy. So in the stable brain mets included 90% of the cases, we can see a better response with the osimertinib. So in head-to-head trial arm, we can see the most important drug full is the osimertinib, where in fluorotrial, where overall response rate is 18.9 months as compared to the 10.2 months in case of gefitinib and erlotinib. So in advanced non-small cell lung cancers, those cases where there is no targets available, we can use immunotherapy, and especially in the where PDL1 positivity is more than 50%. There we can go for pembrolizumab, or we can combine chemotherapy like pemetrexed or carboplatin with the pembro, or we can use single agent like atezolizumab. In PDL1, where the expression is 1 to 49%, we can go for carboplatin plus cisplatin, or pemetrexed along with the pembro, or paclitaxel carboplatin with bevacizumab plus atezolizumab, or carboplatin plus albumin bound paclitaxel plus atezolizumab. Summarize, patients presents with the either locally advanced in most of the cases, and distant metastatic disease is present in more than 60% of the cases. Although high 30 to 60% of the non-small cell lung cancer patients undergoing surgery in early disease, they eventually fail because of the recurrence of the disease or metastasis. Eventually, they develop the metastatic disease and need for improvement in the neoadjuvant or adjuvant treatment options in early stage in order to improve the outcome. Adjuvant osimertinib will provide a highly effective practice-changing treatment for the patients with the stage 1B, starting from the stage 1B to 3A non-small cell lung cancer after complete tumor resections. In unresectable cases, stage 3 non-small cell cancers, the treatment of choice is concurrent chemoradiation, and it is followed by addition of the durvalumab, which has provided significant overall survival benefit and progression-free survival benefit. An advanced metastatic lung cancer can be managed either with the TKI or other biomarker, actionable biomarker positivity with, and in those cases which is negative, we can add on immunotherapy in case of no tumor mutation is there. Thank you.
Thank you so much, Dr. Pradeep, for such an informative session. Now, let us move on to our next talk. And for that, I would like to invite Dr. Rajiv Jain. He's Associate Professor in Department of Radiation Oncology from Regional Cancer Center, Raipur, and he's going to speak on management of small cell lung carcinoma. Thank you, and over to you, sir. Sir, are you going to present your slides or should we share? So you are on mute, Rajiv, sir. Yes, sir. Um, so should we share the screen or are you? So you are not audible. सर वॉइस आ नहीं रहा है
Hello, Dr. Raju, can you hear me? Hello. Hello, Dr. Pradeep. Dr. Raju, can you hear us? Hello. Raju sir, can you hear us? Hello. Dr. Raju, can you hear us? Hello. Dr. Raju, can you hear us? You have joined from the mobile device, I think, right?
Yeah, I've joined
So
from mobile
you
device.
can speak from mobile and start the video. We'll run the slides from our end. We can do like that. From where you are connected from the mobile.
Actually, I'm using Pradeep sir's computer, and we
No.
can do it from this computer.
Okay, no issue. No issue. You can go ahead from that. You can share
Yeah,
the
you
slide.
just start sharing slide, and we'll do it. Yeah. Hello. My presentation is on management of small cell lung carcinoma. Next slide, please. So, next slide. Small cell carcinoma is a high-grade neuroendocrine carcinoma with high metastatic potential, and it accounts for 13% of all lung cancers. Very dreadful malignancy. 31,000 of all diagnosed cases in 2022. 3-year relative survival is around 10.7%. So, very common disease with a common presentation and very poor survival. Mortality has declined since 2001, largely due to decreasing incidence rather than treatment advances. And no major treatment advances has been seen in small cell carcinoma lung. Most common genetic alteration is TP53 and RB1 inactivation, but there is no targetable or no driver gene mutation presently in small cell lung carcinoma. Next slide. Small cell lung carcinoma staging and what is the general approach? So we generally divide it into two parts. One is limited stage small cell lung carcinoma, and the other is extensive stage small cell lung carcinoma. 1/3 of the patients are from limited stage, and 2/3 of the patient are extensive stage. Can be limited stage can be safely treated with definitive radiation corresponding to TNM staging stage 1 to stage 3. Treatment is radiation or surgery plus chemotherapy followed by PCI. PCI is controversial. PCI is prophylactic cranial irradiation. It is controversial, but 3-year survival benefit is 5.4%, so can be done. Median OS is 28 to 30 months in clinical trial, and prognosis 5-year overall survival is around 30%. Most of the patient in limited stage small cell lung carcinoma are going to recur. Extensive stage small cell lung carcinoma are 2/3 of the patient, and they are stage 4 disease with M1A or M1B and T3 or T4 due to multiple lung nodules or volume too large to be treated with definitive radiation. Treatment is chemotherapy plus immune therapy, and median OS is 12 months, and 5-year OS, 5-year relative survival is 3%, very poor. And newer data with Caspian trial shows that it can be increased to 17.6 months. There are ongoing trials, but ongoing need to for efficacious treatment for all patients with small cell lung cancer. Next. So this is the actionable or targetable mutations are very less in in small cell lung carcinoma. That is a major reason for having a poor prognosis. Next slide. History of transcriptionally defined subtypes of SCLC. So coronary, there are long history from 1985 to 2018, and earlier it was classified. It was divided as neuroendocrine and non-neuroendocrine variety. Then neuroendocrine was divided into classical variety and variant type of ASCLC and neuro rod 1 trial, and then multiple it has been divided, but the proposed nomenclature is SCLCA and SCLC N neuroendocrine and non-neuroendocrine SCLCY and SCLCP. Next slide. immunotherapy options for treatment naive extensive stage SCLC. Next slide. Present guidelines says that adding immunotherapy to chemotherapy in SCLC is going to increase the overall survival. Chemotherapy-induced tumor cell killing may induce tumor antigen release and exposure to immune system. PD-L1 overexpression lead to immune cell evasion and T cell inhibition. So PD-L1 is a major target in in small cell lung carcinoma as well, to restore the tumor specific T cell immunity by adding immunotherapy, and it causes a reversal of immune suppression leading to deeper and more durable systemic anti-tumor response. So what we can see that this is a tumor and it has multiple PDL1 type of ligands. So when PDL1, the PDL receptor and PDL target, they do not, so our drug actually have an overexpression, these cells have an overexpression of PDL1. It leads to immune cell evasion and T cell inhibition. So when we inhibit this PDL1, so the chances of evasion decreases and systematically tumor specific T cell immunity increases, and it improves the overall tumor microenvironment and leads to tumor cell death by T cell. Next slide. Or what is the key studies for immune checkpoint inhibitors in SCLC? So the first study was done by ipilimumab plus chemotherapy in March 2015, and then next we have from 2018 IM Power 133 with atezolizumab plus chemotherapy. Then Capsion trial in 2019 with durvalumab and chemotherapy. And in May 2020, there are two trials for EAF 5161 nivolumab plus chemotherapy and Keynote 604 pembrolizumab plus chemotherapy. In October 2000, in June 2017, they had a maintenance trial for pembrolizumab maintenance NCT 02359019 and checkmate trial on IO plus IO in nivolumab plus ipilimumab. And then second line, there is another three trials for second line chemotherapy in SCLC. One is checkmate 032 trial in IO plus IO, nivolumab plus minus ipilimumab, Keynote 028, and checkmate trial 331 nivolumab monotherapy, and Keynote trial 158028 in pooled analysis for pembrolizumab monotherapy. Next slide. Phase 3 trial, addition of anti-PD-L1 checkpoint inhibitor to first-line platinum plus etoposide in advanced stage SCLC. So IM Power 133 adds atezolizumab versus placebo, and atezolizumab is continuous till progression of the disease versus placebo is also continued. Co-primary endpoint is overall survival and PFS by investigator, and secondary endpoint is ORR, overall response rates, and DOR or safety. So, and the second trial is Caspian trial, Caspian 3. Caspian 3 has, they adds durvalumab plus treme plus EP, or they also add durvalumab alone with EP. So they also have a maintenance of durvalumab for every 4 weekly until disease progression. And the third arm had only EP with optional PCI. Primary endpoint was in this was also OS and PFS and ORR. Next slide. So if we see the IM Power 133 adding atezolizumab to chemotherapy, they actually increased the improved overall survival. In atezolizumab, the median OS was 12.3 versus placebo 10.3. That is, HR hazard ratio is 0.76, and it is significant. Then Caspian trial as well demonstrated a good median OS of 12.9 months versus 10.5 months, and HR is 0.75. Next slide. So IM Power 133 atezolizumab plus EP followed by maintenance atezolizumab. It was a double-blind study. ECOG performance score 0 and 1 type of patient were taken, and brain metastasis could have been present either treated or asymptomatic, and platinum agent was carboplatin. And dose frequency was every 3 weekly. Number of chemotherapy cycles were 4, and PCI was permitted during maintenance. In Caspian trial, it was an open label WHO performance score 0 to 1. Asymptomatic patient treated with stable off steroid anticonvulsant for more than 1 month, and carboplatin or cisplatin both can be used, or induction every 3 weekly, and maintenance was done every 4 weekly. And durvalumab arm 4 and control arm was 4 to 6. Durvalumab arm not permitted, and the PCI was not permitted in durvalumab arm, and control arm it was permitted. Next slide. So if we see PDL1 status does not correlate with response in small cell lung carcinoma, and most of the patient had a response with in keynote trial with pembrolizumab plus EP, and most of the patient had response in this analysis. And if you see Caspian trial as well, they had adding durvalumab or adding any IO in spite of a PDL1 status benefited. Patient had a benefit of adding IO with chemotherapy. So PDL1 evaluated patient had an outcome similar to ITT. That means PDL1 scoring was not that important in deciding IO in SCLC. Next slide. Checkmate trial 451, nivolumab, IO plus IO, nivolumab plus ipilimumab, and nivolumab versus placebo or maintenance therapy for extensive stage small cell lung carcinoma. There is a randomized phase 3 maintenance trial. This is for patient with extensive stage SCLC, ongoing response of a stable disease following first line chemotherapy, platinum-based chemotherapy, and no symptom CNS metastasis. So nivolumab plus ipilimumab versus nivolumab alone. So and followed by maintenance of nivolumab every 2 weekly or until disease progression. The primary endpoint was OS with nivolumab and ipilimumab. Secondary endpoint was PFS with nivolumab plus ipilimumab. Next slide. So if we can see this checkmate 451 trial, there was no OS benefit with maintenance nivolumab plus ipilimumab versus placebo. So the median OS was around equal 9.2 to 9.6, and HR was 0.92. It was insignificant. Next study. Frontline chemoimmunotherapy agent in SCLC, summary of efficacy. So if we can see that all the two drugs, atezolizumab or durvalumab, had the similar kind of efficacy in PDL1 mutated patient versus non in PD1. All the trials they had almost similar efficacy, and PDL1 and PD1 agent are similarly effective in SCLC. Currently, only durvalumab and atezolizumab are FDA approved in frontline setting. No benefit when CTLA4 combined with EP. Means IO plus IO do not had a added benefit in this group of patient, and this is different from an NSCLC. Next slide. Practical consideration of dosing atezolizumab. In 2019, FDA approved atezolizumab plus carboplatin and tocoside for first-line treatment of adult with extensive stage small cell lung carcinoma. 3 different dosing schedules are approved: 840 mg every 2 weekly, 1200 mg every 3 weekly, and 1680 mg every 4 weekly. Only atezolizumab to 1200 mg every 3 weekly study in IM Power 133 trial, category 1 indication. The treatment already discussed, it is atezolizumab plus carboplatin plus etoposide, 1200 mg every over 1 hour, every 3 weekly, and carboplatin AUC into 5 mg per ml per minute, and by IV infusion over 30 to 60 minutes, and etoposide 100 mg for day 1 to day 3. And atezolizumab maintenance 1200 mg every 3 weekly. until disease progression or unacceptable toxicity. So, next slide. And practical consideration for dosing of durvalumab. So durvalumab, FDA approved durvalumab plus etoposide in either carboplatin or cisplatin. Approved dosing is weight more than 30 kg, 1500 mg every 3 weekly with chemotherapy 4 cycles, then 1500 mg every 4 weekly in a single agent. And if weight is less than 30 kg, 20 mg per kg 3 weekly, followed by chemotherapy plus 4 cycles, then 10 mg per kg every 2 weekly as single agent. So induction is with 4 weekly 4 into 21 days of durvalumab platinum plus etoposide. Durvalumab 1500 mg IV over 60 minutes on day 1, and then carboplatin etoposide along with the regular EC protocol, and maintenance with durvalumab 1500 mg IV every 4 weekly until unacceptable toxicity or disease progression. Next slide. Immune related adverse event in small cell. So what are the immune related adverse events in small cell lung carcinoma? IAE is surveillance and management of same of the other malignancies. When IO is combined with chemotherapy, safety profile for each are unchanged. Toxicities are additive, not synergistic. So neurological paraneoplastic syndromes considered immune mediated and often a no-go for IO. Most common related side effects of IOs are pneumonitis or colitis or cardiology, neurology, rheumatology. Another one is thyroid related problems. So we need to regularly see T3, T4, TSH variety because it can also mimic as Hashimoto thyroiditis and cause hypothyroidism mainly. In some cases, it can cause hyperthyroidism. Next slide. Hypothyroidism event is 25 in atezolizumab versus placebo, and hypothyroidism event is 11 versus 5. So it can easily relate to immune related thyroid events and can cause diarrhea, that is colitis, and dermatitis rash, uh, and hepatic events and pneumonitis. And if we have if the toxicity is more than grade 3 toxicity, then only we need to stop immune therapy. Otherwise we can easily manage within grade 1 and grade 2 toxicity. Next slide. Management of immune-related adverse event, mild to moderate, provide symptomatic management. If needed, delay immunotherapy until IRAE is resolved to less than grade 1. If IRAE does not improve, give steroid. So one thing is there, if whenever we need to give immunotherapy, we don't need to give any pre-medication before immunotherapy. If either steroid is needed for any adverse event, we need to give it after immunotherapy. Because corticosteroid they generally decrease the efficacy of immunotherapies. And if there is severe AE, we need to discontinue immunotherapy and immediately start a steroid. And doesn't if adverse event does not improve, we need to give anti-TNF therapies and provide inpatient and support care as needed. And supportive care, we need to monitor BP, give proton pump inhibitor, antimicrobial and antifungal prophylaxis, and vitamin D and supplement to prevent osteoporosis. Key aspect of safety during treatment with immunotherapy includes early recognition, patient education, and multidisciplinary management. Next slide. Prophylactic cranial PCI. So what is the role of PCI? Approximately 2/3 of the patient with SCLC are going to develop brain metastasis within 2 years. So PCI is a mainstay in the localized stage SCLC following a curative chemoradiation. 5.4% absolute survival benefit within after at 3 years. 3 years, PCI now used less often in ESSCLC, giving conflicting data from EORTC OS trial and Japanese trial. So Japanese trial says that there is no benefit, while EORTC trial says that there is a benefit. So there is a conflicting evidence regarding PCI. ongoing research and debate on the role of PCI. PCI in the era of chemo and plus IO for extensive stage SCLC. Hippocampal avoidance in PCI, and what other research are going on? MRI brain surveillance alone versus MRI brain surveillance plus PCI. And last is stereotactic radiosurgery versus whole brain radiotherapy. And MRI brain surveillance every 3 monthly is reasonable in lieu of PCI for patient with extensive stage SCLC responding to treatment. Next slide. These are the ongoing trials. Maverick trial, NRG CC003 and NRG CC009. Next slide. First line combination of immunotherapy plus chemotherapy. So this is the summary. Addition of PDL1 inhibitor to platinum and etoposide chemotherapy significantly improves survival in extensive stage SCLC. Atezolizumab and durvalumab are the two agents which are currently FDA approved. And addition of CTLA4 inhibition to platinum and etoposide plus PDL1 does not add a benefit on SCLC, like adding a ipilimumab or tremelimumab, adding an IO to the present durvalumab or atezolizumab is not going to increase the OS or PFS. Safety outcome consideration with known safety profile of each agent, and PDL1 inhibition plus chemotherapy is a standard of care for first line treatment of SCLC. Next slide. Overview of therapeutic options for relapse ESC. Next slide. We have already discussed on all those patients who have prolapse with chemotherapy, which have failed relapsed after chemotherapy, can like there is either we have to divide it into two parts. If they have relapsed less than 6 months or more than 6 months. If they have relapsed within less than 6 months, so we need to the other agent which we can add is topotecan or inotecan or doxorubicin or lubricidine. But with this, and if they have relapsed after 6 months, then we can repeat the original re-challenge with the original immunotherapy agent plus carboito. Next slide. So the dosing of topotecan. Topotecans are generally oral capsules available. So per oral or IV preferred regimen for patient with SCLC relapsing less than 6 months. Other recommendations for those relapsing more than 6 months. Can be difficult to obtain insurance approval for oral topotecan. IV administration or burdensome for some patients. Topotecan 2.3 mg per meter square per day per oral every day into 5 days starting on day 1 of 21 days cycle. Or IV, if we give IV 1.5 mg per meter square over 30 minutes every day for 5 days. Patient with ECOG performance score 2, consider dose reduction and growth factor support, because generally oral topotecan or IV topotecan, they have a high incidence of myelosuppression. So we need to be very careful with this drug, and proper GSF prophylaxis is needed. Next slide. Second line, lubrinectedin in SCLC. Lubrinectedin is synthetic analog of marine alkaloid trabectedin, inhibits active transcription, and there is a single arm phase 2 study in as monotherapy as second line SCLC, which shows that overall response rate is 35.2%, and in platinum sensitive it is 45%, in platinum resistant it is 22.2 months. So maximum change in tumor size by investigator is around 34.7 months, and it decrease in tumor size is 65.3 months in patients. Next slide. Second line, so if you can see in this study, so second line adding lubrinectedin, median OS is 9.3 months and 12-month OS is 34.2 months. In resistant patients, chemotherapy, platinum resistant patient, it is 5 versus 5 and 5 versus 11.9 months. So means platinum sensitive patient, this drug has a better OS as compared to in those patients who are platinum resistant cases. Next slide. And toxicity wise, this has a most of the toxicities are grade 1 toxicities and grade 2 toxicities, but neutropenia is very common in this drug as well, and we need to see neutropenia and manage it properly. Next slide. There is an Atlantis trial for doxorubicin plus lupretadine versus topotecan or CAV for extensive stage SCLC, and they used doxorubicin along with the drug or versus topotecan. Primary endpoint was OS, and secondary endpoint was PFS and tumor response. Next slide. There was no OS benefit of adding the two drugs versus topotecan, and no significant difference in OS benefit. And subsequent analysis also show no significant difference between arms based on stratification factors. So lupretadine, if we want to give, so single agent is good. Next slide. Practical consideration, and the dose is 3.2 mg per meter square IV over 60 minutes every 3 weekly until disease progression. Next slide. Treatment option for relapse ESC. So if we summarize it, if it relapse less than 6 months, topotecan or single agent lurbinectedin. If it relapse more than 6 months and performance score 0 to 2, we can re-challenge with the original therapy, original regimen. Or if it relapse more than 6 months, topotecan or all the drugs can be given, but overall results are not that strong. And clinical trial is strongly recommended for any patient who has relapsed with ES with SCLC. Next slide. Supportive care, relaxiclip for prophylactic against chemotherapy-induced myelosuppression in SCLC. So trilaciclip, the intravenous CDK4/6 inhibitor given before chemotherapy for temporary arrest CDK4/6 dependent hematopoietic stem cell in GS1 trial. Because SCLC cell replicate independently, they are susceptible to cytotoxicity in CT, but not TRAC. Next slide. Dosing is triaciclib is 240 mg per meter square over 30 minutes within 4 hours before chemotherapy on each day of chemotherapy is administered. Next slide. Biomarkers for immunotherapy in SCLC. Where are we and where we are going? Next slide. So there are a lot of biomarkers, but we don't have a proper biomarker presently for like ASCLC and Neurorod or POF 2F3 and YAP3. Next slide. They are promising, but presently we don't have drug for the particular biomarker. OS with atezolizumab plus chemotherapy. This is again IM Power 133 trial, and it shows that there is a benefit for adding atezolizumab or durvalumab in patient with with chemotherapy in extensive stage SCS. Next slide. Key clinical trials in SCLC. Next slide. These are the all key clinical trials. This IO monotherapy versus IO plus IO, and IO monotherapy and IO plus chemotherapy. We have all discussed most of these trials, and we only thing which is take home point is adding Tecentrix, that is atezolizumab along with chemotherapy, or durvalumab along with chemotherapy have significant benefit, uh, have a significant PFS benefit, but not OS benefit right now. They are already recruiting patient, and this is the only thing which we can add, have some benefit. Next slide. Pediatric this is a randomized double-blind multi-center phase 2 study, durvalumab plus tremelimumab and placebo plus placebo. Next slide. Next slide. Skip करते हैं ना. After consolidation, radiation plus immunotherapy for there is one more trial which is very important for us. Like if we can do a radiation plus immunotherapy for extensive stage SCLC. If this is radio immunotherapy and XRT to up to 5 sites of every day for day 1 to day 5, week 1 to week 5 with atezolizumab over 60 minutes and from day 1 of 21-day cycle or versus atezolizumab alone. And primary endpoint was PFS and phase 2. And this is an important trial for us because it is radio immunotherapy which can benefit the patient. Next slide. Emerging data from key clinical trials. Next slide. So phase 3 Astrum trial, first line serpulilumab plus carboplatin plus etoposide, and it is added to chemotherapy along with is another trial. Next slide. Astrum trial says that adding serpulilumab plus EP has a better OS 15.4 months compared to 10.9 per month in placebo plus EP. Next slide. And capstone trial is adagrelimab plus chemotherapy. Next slide. And this capstone trial also says that there is a median OS benefit of 15.3 months versus 12.8 months in addition of adagrelimab to chemotherapy. Next slide. Then skyscraper 02, another study with when we are adding atezolizumab plus chemotherapy plus tergalolumab for immunotherapy. It's IO plus IO plus chemotherapy, double IO. So primary endpoint was median PFS and median OS analysis set. So adding tergalolumab to first line atezolizumab did not improve OS. Adding a IO plus IO is not benefiting in small cell lung carcinoma when we see non-small cell lung carcinoma. Next slide. Phase 3 resilient study, part 1 and part 2. Liposomal irinotecan in relapse SCLC. And they added liposomal 72 or 85 mg per meter square IV over 90 minutes. Next slide. Resilient study, part 1 was efficacy and it was efficacious. Median DOR was 8.80 month in 85 mg per meter square, 2.99 month in 70 mg, and all doses was 3.7. Next slide. There is no prophylactic use of GCSF in 3 out of 25 patients treated with liposomal irinotecan at 70 mg per meter square received GCSF after initiation. So increasing dose of liposomal irinotecan, actually we had to use GCSF. Next slide. Take home messages: platinum plus etoposide plus anti-PD-L1 is a standard of care in extensive stage SCLC regardless of PD-L1 status. MRI brain surveillance every 3 monthly is reasonable in lieu of PCI for patient with extensive stage SCLC responding to treatment. Expanding options for second line ESC-ELC with ibrutinib comparable activity to topotecan and easily administered. Biomarker for benefits of IO remain elusive, and PD-L1 status does not predict benefit from first line IO plus chemotherapy. Next slide. Done. Thank you.
Thank you so much, Dr. Rajiv, for such an instructive session. Now let us move on to next talk, and for that I would like to invite Dr. Rahul Singh. He's associate professor in Department of Radiation Oncology from Regional Cancer Center, Raipur, and he's going to speak on latest developments in early stage NSCLC.
मेरे को वापस भेज दो इसको बोलना पड़ेगा You don't have to upload. I'm uploading everything. Upload. I'm uploading my screen share.
So should I show your slides?
iPhone. उसी में वो भी अच्छी के बाद चला जाएगा Please check this.
Yes, sir. But 2 seconds. Okay, so you can start.
That's right. Good afternoon, respected Professor Pradeep Chandrakar sir, and all my colleagues and students. Today I'm going to present some slides on the management of early stage or locally advanced NSCLC. Although much have been described by Professor Pradeep Chandrakar sir already. I will just add on the latest trials that have been added, and those which have been incorporated in NCCN. NCCN right now we are following right now following AJCC 8th edition. It has slight changes from the 7th one. Change. All the this is the change from 7th to 8th edition. T1 7th edition stage T1. It was T1A and T1B. Right now it has been changed to T1 1A, B, and C. Sizes from less than 1 centimeter to 3 centimeter. And T2A, T2B, it is same, but sizes from T2A sizes more than 3 but less than 4. T2B it is more than 4 but less than 5 centimeter. T3 it is more than overall it is more than 7 centimeter. It was more than 7 centimeter. Now right now it is T4. It is earlier it was T3. Now that has been changed to T4. So right now T1 is 1 to 3 centimeter. T2 is 3 to 5 centimeter, and T3 is T4 is more than 7 centimeter. And in distant metastasis, we have added M1B, M1A, B, and C. Change. Yeah, change. This is the management which is given in NCCN for the stage 1A, peripheral, T1 ABC, and N0 tumor. After a pre-treatment evaluation, if the mediastinal node is negative, we take the we have two options: operable and medically inoperable. If it is operable, we go for surgical exploration plus a resection plus mediastinal lymph node dissection, and after that we go for adjuvant treatment in the form of either chemotherapy or even adjuvant radiotherapy or targeted therapy. And if it is medically inoperable, we go for definitive RT, preferably SABR. And if the mediastinal lymph node comes out to be positive, then it is staged as a 3A, 3B, and be treated accordingly. Next slide. After that, 1B, management of stage 1B to 3A. Here also we do the pre-treatment evaluation, and if the mediastinal node is negative, then we go for surgery, and if it is operable, then we go for surgery, and same as before, we will go for adjuvant treatment. And if it is medically inoperable, then if the node is negative, then definitive RT, preferably SABR, and followed by adjuvant chemotherapy for the high risk stage 1B and stage 1B to 2B disease. And if it is N1, here it is to be remembered that if the node is positive, then we go for definitive chemoradiation, and following definitive chemoradiation, as we have already studied right now, that we go for durvalumab. And if the mediastinal nodes are positive, then it is obviously stage 3 and 3A to 3C. Next slide. Next, adjuvant treatment after surgery. So in the initial slide, what we studied, after surgery, we go for adjuvant treatment. So these are all the adjuvant treatment that we can go after surgery. But these are all these recommendations are category 2A unless otherwise indicated. So we have to be very cautious, and all these recommendations are just the recommendations, and they are not to be blindly followed. Next. treatment of stage 2B to 3A, node is N0 to N1, not N2. Then that is stage 3, stage 2B, T3 invasive, N0, or T3, T3A, T4 extensive, or N0 to N1. Then here also we'll do the pre-treatment evaluation. And if now according to the side of the tumor, if it is superior sulcus tumor, we can go for chemoradiation. And if it is chest wall, proximal airway, or obviously 3A disease, or unresectable disease, then we can go for either neoadjuvant chemoimmunotherapy followed by surgery, followed by adjuvant RT, or neoadjuvant chemotherapy or CTRT followed by surgery. Next. This is the same thing. Superior sulcus tumor, we see that we can go for preoperative concurrent chemoradiation followed by surgery plus chemotherapy followed by atezolizumab or pembrolizumab. Or if it is EGFR 19 or 21 positive, then osimertinib. If that in superior sulcus tumor, if the tumor is T4 and node is N0, N1, if it is possibly resectable, then we can go for preoperative concurrent chemoradiation followed by surgery. If it is surgical re-evaluation, sorry, preoperative chemoradiation followed by surgical re-evaluation. If it seems to be resectable, then we can go for surgery, then chemotherapy followed by atezolizumab. And if it is unresectable, then we have to complete the chemoradiation up to 60 gray. This preoperative concurrent chemotherapy was up to 45 to 56 gray. Now, if it is unresectable tumor, then we can go for definitive concurrent chemoradiation followed by durvalumab. Next. So this was the second setting. One was the superior sulcus tumor, and after that, all other options, chest wall, proximal airway, or mediastinum involvement. Here we go for surgery that is preferred after the preoperative systemic therapy. So we can see that in this subset of population, there is the role of preoperative systemic therapy if it is planned. Or we can go for concurrent chemoradiation or chemotherapy. If it is the surgery and the margins are negative, then we can go for chemotherapy followed by atezolizumab or pembrolizumab or osimertinib. If the margins are positive, then we can think for the resection and chemotherapy. Otherwise, go for chemoradiation. In concurrent chemoradiation arm, we can go for surgical evaluation, then surgery. If the margins are negative, then observe it. If the margins are positive, then we should go for re-resection. And if we cannot go for re-resection, then RT boost. Stage 3A, that is T4 and N0 M1, unresectable disease. That is the same arm, Pacific trial arm. Definitive concurrent chemoradiation followed by durvalumab. Next. Now coming to the N2 disease. N2 disease, this is very important for us because it has, here we have got a definitive established role of radiation. Stage 3A, 3B. Here also we have to do the pre-treatment evaluation. And we have to go for mediastinal biopsy finding and resectability. If it is it is N2, N3 nodes negative, that is, it is N1, then we can go for early treatment. It will take it as early disease and go for treatment. N2 positive disease, there is a role of radiation, concurrent chemoradiation in this set of patient. N3 positive, there is the role of neoadjuvant immunotherapy and followed by CTRT or sequential CTRT followed by surgery. Next, I'm not taking the metastatic disease. Now, after mediastinal biopsy finding, if it is T1 to T3 or N0 to N1, including T3 with multiple nodules in the same lobe, and if it is resectable, then we will go for surgical resection plus mediastinal lymph node dissection or systemic lymph node sampling. And after that, we will go for adjuvant treatment. Adjuvant treatment in the form of radiation, concurrent radiation, or sequential radiochemo we can give, followed by targeted therapy, immunotherapy. If it is medically inoperable, then we will treat it according to the clinical staging. If it is now if the disease is T2, T1, T2, T3 other than invasive or N2 positive, then we will definitely go for definitive concurrent chemoradiation. That is category 1 indication. N2 disease, definitive concurrent chemoradiation has got the category 1 indication. Or we can go for induction systemic therapy followed by radiotherapy. In T3 invasive disease, N2 node positive and N0 definitive chemoradiation followed by durvalumab, as already stated. Next. So now we can, as you can see, that we are slightly shifting to the perioperative or neoadjuvant setting before therapy before the definitive treatment like surgery. Next, I'm taking radiotherapy first. So radiotherapy in early stage NSCLC. Radiotherapy has a potential role in all the stages of NSCLC, either as definitive or consolidative or palliative therapy. Higher conformal RT such as IMRT, given in RTOG 0617, or proton therapy should be used in the setting of prior RT, potentially with hyperfractionation to reduce the risk of toxicity. In early stage disease, stage 1 node negative disease, SABR has achieved good primary tumor control rate and overall survival higher than the conventionally fractionated radiotherapy. Although SABR is not proven equivalent to lobectomy, some prospective series have demonstrated similar overall and cancer-specific survival. For in a patient treated with surgery, post-operative radiotherapy is not recommended unless there are positive margins. For centrally located tumors, defined variably as within 2 centimeters of the proximal bronchial tree or abutting the mediastinal pleura, and even ultracentral tumor, defined as abutting the proximal bronchial tree. 4 to 10 fraction risk-adapted SABR regimen appears to be effective and safe, while 54 to 60 gray in 3 fraction is unsafe and should be avoided. However, particular attention should be paid to tumor abutting the bronchial tree and esophagus to avoid the severe toxicity. RTOG 0813 evaluated the toxicity of 5 fraction regime and found no high-grade toxicity at 50 gray in 5 fraction. Locally advanced stage 2-3 disease, concurrent chemotherapy RT is recommended for the patient in inoperable stage 2, node positive, or stage 3 disease. Preoperative systemic therapy and postoperative RT is an option for the patient with resectable stage 3A, minimal N2, and treatable with lobectomy. Preoperative concurrent chemotherapy RT is an alternative option for patients with resectable stage 3A NSCLC, and it is recommended for resectable superior sulcus tumor. I discussed it before also. Superior sulcus tumor, preoperative concurrent chemoradiotherapy. The optimal timing of RT in trimodality therapy, preoperative with chemotherapy or postoperative, is not established and it is controversial. In patients with clinical stage 1-2, upper stage surgically to N2, with completely resected disease, 2 randomized studies did not show an overall survival benefit of both. The 2 randomized study where one is lung art and one other was port C trial. Next. This was a lung art trial for 3D CRT was used in this patient and this subset of in this study. Next. This is the revised STAR. The initial STARS trial, the study was aborted due to the less number of patient accrual, but later on it was completed with 83 patients something, and it advocates the efficacy of SABR in lung. Next. Comparing the studies evaluating the conventional versus SABR, this is for early stage NSCLC. Two studies were there, SPACE and Chisel, and we can see that in SPACE trial, in conventional arm, 70 gray 35 fraction was there, and in SABR 66 gray in 3 fraction was given. So there were more toxicity, and local control was good. When in conventional arm it was 85%, in SABR it was 86%. But there were a significant amount of toxicity, grade 1 to grade 4 toxicities like esophagitis and pneumonitis. At the same time, Chisel trial was done. Number of patients were 101. In this trial, the conventional arm was having 60 grade 30 fraction or 50 grade 20 fraction, and SABR arm was having 48 grade 4 fraction or 54 grade 3 fraction. So this arm has showed us a significant improvement. Next. Another was, this is for the locally advanced comparison of studies evaluating the concurrent chemotherapy and palliative RT versus single modality treatment. In locally advanced non-operable tumor, the Pacific, like the Pacific trial, in which we are not operating the patient. In the Pacific trial, durvalumab was continued after the concurrent CTRT. These two trials, phase 2 trials and phase 3 RCT trials. One was from now Rocky and other was from Strom. They tried some palliative radiation along with the chemotherapy. Here you can see that randomized arm in this phase 2 RCT arm, and there were two randomized arm, and in one arm 30 grade 10 fraction was given, and another arm 3 cycles of cisplatin vinorelbine with concurrent RT 30 grade in 10 fraction with 3 cycle it was given. Response rate in RT arm was definitely better. It was 53 versus 27%. Median overall survival was 12.9 in the RT arm, and RT plus CT arm, and in only RT arm it was 9%. And the other study of Strom, here also you can see that 4 cycles of carboplatin plus vinorelbine was given, and in other arm 4 cycles of carbo vinorelbine along with 45 gray in 15 fraction with 2 cycles was given. And here we can see the median overall survival. It was similar to the previous Norogi study. It was 12.6 months versus 9.7 in the plain chemo arm. Next. This was the Pacific study. Sir has already described that study. Next. These are the principles of radiation therapy. This is for just for the knowledge. Next. 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 These are the few studies for neoadjuvant immunotherapy. Keynote 671, IM Power 030, Checkmate 770, and AGN study. Keynote 671 is for pembrolizumab plus concurrent chemotherapy versus placebo plus concurrent chemotherapy, followed by surgery. Adjuvant pembrolizumab or placebo. IM Power 030, it is for atezolizumab plus concurrent chemotherapy versus placebo plus concurrent chemotherapy, followed by surgery, and adjuvant atezolizumab or best supportive care. Likewise, Checkmate 770 is for nivolumab plus concurrent chemotherapy versus placebo plus concurrent, followed by surgery. And fourth is AGN, that is for durvalumab plus concurrent chemotherapy versus placebo plus concurrent, followed by surgery. Next. Checkmate 816. This was started in 2021, 17, I guess. And this year in ASCO 23, the 5-year survival update was published, and it has established the role of nivolumab plus chemotherapy in the resectable lung cancer. Next. This was the schema of Checkmate 816. Key eligibility criteria was newly diagnosed resectable stage 1B to 3A NSCLC. ECOG performance status was 0 to 1. No known sensitizing EGFR mutation or ALK alteration. Number of patients were 358. There were two arms, nivolumab 360 milligram 3 weekly plus chemotherapy 3 weekly. Or second arm was chemotherapy 3 weekly. And radiological restaging was done, and the surgery within 6 weeks post-treatment was done, followed by optional adjuvant chemotherapy plus minus RT. Next. So it has shown us the event-free survival benefit. I think the overall survival and the DFS has not yet been reached. Next. Next. You can see the pathological complete response. It is 24% in nivolumab plus chemotherapy versus 2.2 in chemotherapy alone in all the stages together. Next. This is the median overall survival of till 24 months. Overall, this study has not yet been completed. And we can see nivo plus chemotherapy, it was 82.7 versus 70.6 in the other arm. Next. Checkmate 77T. Key eligibility criteria was a T2 stage 2A to 3B, no prior treatment, COG 0 to 1. 452 patients were taken. Here, one arm was nivolumab plus storage-based platinum doublet chemotherapy, up to 4 doses, 3 weekly. Other arm, placebo plus platinum doublet chemotherapy, up to 4 doses, followed by surgery, followed by nivolumab for 480 milligram, 4 weekly for 1 year, and in other arm, placebo for 1 year. Primary endpoint was event-free survival by blinded independent central review, and secondary endpoints were overall survival, PCR rate by blinded independent pathology review, and MPR rate by blinded independent pathology review. Adverse events and SAEs. Next slide. DORA trial. This also, sir has very well explained. Osimertinib versus placebo. Primary endpoint was DFS in patient with stage 2 to 3A, and the secondary endpoints was DFS in overall population. Landmark was 2, 3, 4, and 5 year. Next. In median DFS, in osimertinib arm was 65.8, whereas in placebo it was 28.1. Next. Next slide. This was the DFS by subgroup. We can see that stage 1B, 2A, 2 and 3A, it favors more towards the osimertinib side. Next. Overall survival. We can see at the end of 60 months, in osimertinib it was 88%, and placebo it was 78%. Next. This is stage-wise OS. Next. This is OS by subgroup in overall population. You can see that in every aspect, osimertinib seems to be better. Next. This is new ADORA trial. This is the new trial that has been designed. Here we are going to give the osimertinib as a new adjuvant for 3 cycles, along with chemotherapy. One arm will be placebo plus chemotherapy, 3 cycles, 3 weekly, followed by another arm is osimertinib plus chemotherapy, 3 cycles, 3 weekly, and the third arm is plain osimertinib, 9 weeks, followed by surgery, and we will see the pathological response and clinical response. Next. Next. The overall survival data are still immature with this new ADORA trial. Keynote 671, neoadjuvant platinum-based chemotherapy plus pembrolizumab or placebo followed by resection, and adjuvant pembro plus or placebo in the early stage NSCLC. It is a randomized double-blind phase 3 trial stratified by disease stage, squamous versus non-squamous, geographical region, PDL1 TPS. PDL1 का ratio क्या है? More than 50 or less than 50. Patients with resectable stage 2, 3A or 3B and 2 NSCLC with no prior therapy able to undergo surgery, evaluated for PDL1, ECOG 0 to 1. Number of patients were 797. Pembrolizumab 200 milligram IV 3 weekly plus cisplatin plus gemcitabine or pemetrexed according to the histopathology for up to 4 cycles, and another arm placebo 3 weekly along with cisplatin plus gemcitabine or pemetrexed for up to 4 cycles, followed by surgery, and followed by pembrolizumab 200 milligram 3 weekly for up to 13 cycles versus placebo IV 3 weekly for up to 13 cycles. Primary endpoint will be event-free survival as per investigator and overall survival. Secondary key point will be pathological response, clinical response per blinded independent pathology review. Next, keynote 671 baseline characteristic. Here you can see that the PDL1 almost in pembro arm, it was more than 132 patients were having more than 50% of PDL1 TPS, and placebo arm about 134% were having more than 51% of the PDL1. Non-EGFR mutations were also there, but there's a contraindication or restrictions for immunotherapy when there is some driver mutation positivity. We have to be cautious while giving the immunotherapy, as the effectivity decreases with these driver mutations positivity. Next. Pathological response by blinded independent pathologist review. This was the mean pathological response. It was 30% in the pembro arm, and in placebo arm it was 11%. And pathological clinical response, it was 18% in pembro arm and only 4% in the placebo arm. Next. This is the event-free survival. We can clearly see at the end of 24 months, it was 62.4 in the pembro arm versus 40% only in the placebo arm. Next. Primary endpoint was overall survival. 24-month rate, it was 80% in the pembro arm, and placebo, it was 77%. Next. NeoTorch, this is a study for toripalimab. It is also immune checkpoint inhibitor. So it has been studied along perioperatively along with platinum-based chemotherapy versus platinum-based chemotherapy in the resectable stage 2 and 3 non-small cell lung cancer. In neoadjuvant setting, toripalimab 240 milligram IV plus platinum-based chemotherapy were given for 3 cycles, 3 weekly, versus placebo plus platinum-based chemotherapy, 3 cycles, 3 weekly. Patients were newly diagnosed, resectable, EGFR ALK mutation negative, and total number of patients were 500. So after neoadjuvant therapy, surgery was done, and after surgery, adjuvant toripalimab was given 240 milligram IV along with platinum-based chemotherapy for 1 cycle, and in another arm, placebo plus platinum-based chemotherapy for 1 cycle. In maintenance, toripalimab was given up to 13 cycles and placebo also for 13 cycles. Primary endpoint was EFS and secondary was overall survival, clinical response. Next. Next. So we can see the primary endpoints. 12 months EFS was 84.4% in toripalimab plus chemotherapy, whereas in placebo it was only 57%. After 24 months of follow-up, it was 64% in toripalimab, and in placebo arm it was 38%. Next. At some now I'm going to read some adjuvant trials. This is IM Power 010 adjuvant atezolizumab versus best supportive care. It was completely resected, done in completely resected stage 1B to 3A NSCLC. Stage 1B tumor more than 4 centimeter, ECOG 0 to 4. Lobectomy or pneumonectomy should have been done for tumor tissue for PD-L1 analysis. Cisplatin plus pemetrexed, gemcitabine, docetaxel, or vinorelbine for 1 to 4 cycles according to the histopathology. Ratio was 1:1. Total number was 1280. There was no crossover. Atezolizumab 1200 milligram per 21 days for 16 cycles was given in one arm, and survival follow-up was done. Stratification factors were male-female, stage 1B versus 2 versus 3A, histology, and the PD-L1 tumor expression status. Primary endpoint was DFS status, PD-L1 more than 1%, in stage 2 or 3A population, all randomized stage 2, 3A population. And secondary key endpoints were overall survival in ITT population, DFS in PD-L1 more than 50%, stage 2 to 3A population, 3-year and 5-year DFS in all 3 population. Next. You can see after 36 months, median DFS was 60% in atezolizumab versus 48% in the supportive care. Next. DFS in the all randomized stage 2 to 3A population. You can see after 36 months, it was 55.7% in atezolizumab arm, whereas in BSC, best supportive care arm, it was 49.4%. Next. This was overall survival in PD-L1 more than 1%. And another slide is for all randomized stages of 2 to 3A, and the third arm is for ITT. Next. This is the safety profile, which was acceptable. Next. This is the second keynote 091. This was for pembrolizumab. And this has been incorporated in the NCCN version 3 of 2023. Eligibility for registration was confirmed stage 1B, 2 or 3A, complete surgical resection with negative margin, provision of tumor tissue for PD-L1 testing. Eligibility for randomization, no evidence of disease, ECOG 0 to 1, adjuvant chemotherapy considered for stage 1B disease, strongly recommended for stage 2 and 3A disease. 2 arms were there, pembrolizumab 200 milligram 3 weekly for 18 administrations, around 1 year, and the placebo, that was also for 18 administrations. Primary endpoint was DFS in overall population and DFS in PD-L1 more than 50% population. And the secondary endpoint was DFS in PD-L1 TPS more than 1% population, and overall survival in overall PD-L1 TPS more than 50% and PD-L TPS more than 1% population. Lung cancer specific survival in the overall population and safety. Next slide. This is the Asian study for durvalumab plus CT. This also has been explained by sir. It was a phase 3 trial of neoadjuvant adjuvant durvalumab versus placebo in the resectable stage 2-3 NSCLC. in the press release in June 30, 2022, Asian studies showed the improved PCR in the resectable stage 2-3 NSCLC. In the neoadjuvant treatment, durvalumab plus chemotherapy was given three weekly for 4 cycles. Chemotherapy was platinum based, and second arm was a placebo plus chemotherapy, same for 4 cycles. After that, surgery was done, and after that, adjuvant treatment, durvalumab was given for 12 cycles versus placebo. Primary endpoint was PCR versus event-free survival. Next slide. So these are the results of AG trials. These were published recently. You can see that after 24 months, the median event-free survival for the durvalumab arm was 63.3%, whereas for placebo arm it was 52.4%. Next. Clinical response. Pathological clinical response, it was 17.2% in durvalumab arm, whereas 4.3% in the placebo arm. There was difference of 13%. And in the pathological response, looking at the pathological response, it was 33.3% in the durvalumab arm versus 12.3% only in the placebo arm. There was difference of 21%. Next. So this is the take-home message that neoadjuvant chemoradiotherapy has got a role in the management of early stage NSCLC. Long-term follow-up with more number of patients accrual is needed for getting anticipated results with radiotherapy. Immunotherapy along with chemo as neoadjuvant or single agent as maintenance is the new approved treatment for early stage or localized NSCLC, and it significantly improves the survival when incorporated perioperatively. Quadruple modality treatment is the mainstay and can be sequenced according to the stage in early stage or localized NSCLC. Role of immuno-RT has to be researched well with multi-institutional trials. Thank you.
Thank you so much, Dr. Rahul Singh, for delivering such a great talk. So moving ahead, now I would like to invite our next speaker, Dr. Harshita Jain. She's Associate Professor in Department of Radiation Oncology from Regional Cancer Center, Raipur. And she's going to speak on management of advanced and metastatic NSCLC. Thank you, over to you.
Good afternoon. Good afternoon, everyone. I'm going to talk on the management of advanced non-small cell lung cancer and metastatic non-small cell lung cancer. Next slide. As Sir has already said, there has been a paradigm shift in the treatment of advanced non-small cell lung cancer, wherein the initial treatment would be based on histology, and now we have targeted agents, and now there is an emerging role of immunotherapy as well. Next slide. So first and foremost is biopsy, that is to establish the diagnosis, wherein we get to know the histological subtyping, and this biopsy is also sent for molecular testing. So in non-squamous histology, EGFR, ALK. Now, when tissue biopsy is not available, there is something called liquid biopsy which can be done, which is nothing but collecting blood sample containing the cell-free DNA from multiple sources, including the DNA that is shed from the tumor. So this is sent for molecular testing, and it is a minimally invasive procedure. And the main advantage is that, as we all know, that tumor is heterogeneous. So this liquid biopsy may overcome the tumor heterogeneity. However, the limitation of this is that the sensitivity of this test is around 70 to 80%, and specificity is around 100%. That is, we will get to know that this receptor, this molecular mutation is not there, but we will not actually get to know what is there. So it becomes a limitation for this kind of testing. Next slide. Now coming to management of patients with advanced non-small cell lung cancer with actionable alteration. So you guys would have already know that we always talk about something called driver mutation. So there is this particular receptor which is acting more than the other receptors, which drives the cellular growth in tumors. So in non-small cell lung cancer, we look for such targets, and that is called the actionable alteration. So coming to the first one, next slide. We'll talk about EGFR mutation. EGFR mutation is one of the most commonly found mutation in non-small cell lung cancer. Next slide. So the first generation TKIs are gefitinib, erlotinib. Second generation are afatinib, dacomitinib, and third generation is osimertinib. Next slide. So there are a lot of trials which have compared the TKIs with chemotherapy, and all of them have showed an drastic improvement in overall response rate, which is more than double. Median PFS is also drastically improved with the use of TKIs, and even the median overall survival has increased drastically. Next slide. Now coming to FLORA study. This study, it compares osimertinib with standard of care EGFR TKI, that is erlotinib or gefitinib, in first line setting. So here the patients were randomized. It is a double-blind phase 3 study wherein patients with advanced non-small cell lung cancer with adenocarcinoma with EGFR exon 19 or 21 mutation with good performance status and even CNS mets were permitted, and they were randomized into two groups, one receiving osimertinib, the other receiving standard of care TKI, either erlotinib or gefitinib. And this was continued till progression. However, in this study, crossover was allowed. That is, patients who progressed with standard of care TKIs were allowed to cross over and receive osimertinib. The primary endpoint of all the trials that I'll be talking about is the progression-free survival, and secondary endpoint is overall response rate, the disease progression rate. Now, coming to the results of the FLORA study. So can we go to the previous slide, please? So even in this study, there has been a significant increase in the progression-free survival, and that has also translated into increase in overall survival. So, and both of which are statistically significant. Here, even the patients who have had brain mets have also responded very well to osimertinib when you compare it with gefitinib and erlotinib. So when we talk about the adverse effects, in osimertinib arm, the adverse effects were slightly less when you compare it with the standard of care arm. Next slide, please. Now, there may be acquired resistance. As we all know that whenever the patient is put on targeted therapy, they are going to develop resistance at some point. So the mechanism by which the patients who are on standard of care TKIs, that is gefitinib, erlotinib, the method with which they acquire resistance is either loss of T790M, that is the most common, for which we give osimertinib, followed by MET amplification. And sometimes there might be a transformation in the histology, that is from non-small cell, they can transform into small cell transformation. So whenever there is resistance to immunotherapy, we actually divide the patient whether they are undergoing oligoprogression or they have new systemic disease. When they have new systemic disease, we have to do biopsy of the patient and again send for mutation analysis. Whereas if they are just oligoprogression, that is when they have responded to a particular targeted therapy, and following which they have progressed at only few sites, they are categorized under oligoprogression. When oligoprogression is there, local RT plus continuing the same TKI is another option. Or else we can, of course, we can biopsy the patient and check for any resistant mutations. Next slide. Now there are a lot of trials, phase 1 and phase 2 trials, which are going on, wherein TKIs are added with bevacizumab, with other targeted agents to see if they respond better or not. They are still in phase 1 and phase 2 trial. We shall wait for phase 3 trials and their results. Next slide. Now coming to ALK rearrangement positive non-small cell lung cancer. Next slide. There are 4 agents which are given for ALK rearrangement positive non-small cell lung cancer: crizotinib, ceritinib, alectinib, and brigatinib. Brigatinib is available only in US. Crizotinib has been the standard of care, but with the ALEX trial, now alectinib has become the standard of care for ALK rearrangement positive non-small cell lung cancer. Next slide, please. Now coming to ALEX trial, wherein patients with ALK positive non-small cell lung cancer with good performance status who are treatment naive have been randomized into 2 groups, one receiving alectinib and one receiving crizotinib. So it was continued till patient developed either progression or toxicity or withdrawal. No crossover was permitted in this trial. The primary endpoint is progression-free survival, and secondary endpoint is overall response rate. Next slide, please. So now talking about the progression-free survival, as you can all see, the blue graph, this is blue graph is of alectinib and the red one is of crizotinib. You can see that the graphs have separated significantly. The median PFS with crizotinib was around 11 months, whereas with alectinib it is around 35 months. OS, there is, though there is a slight OS benefit with alectinib, this is not statistically significant. Now talking about the hazard ratio, the number of deaths that have happened in alectinib arm is significantly less when you compare it to crizotinib arm. The median PFS for patients with CNS Mets was around 27.7 months with alectinib and 7.4 months with crizotinib. Following this trial, alectinib has become a category 1 recommendation for ALK rearrangement non-small cell lung cancer. Next slide, please. So this is basically a graph showing the incidence of CNS Mets or the progression patients, how they have progressed, whether patients in alectinib arm and patient in crizotinib arm. So patients in alectinib arm, as you can see, had a delayed time to CNS progression when you compare it with crizotinib arm. And this benefit was also seen with patients who did not have CNS metastasis at baseline. Next slide, please. Now, this is again another phase 3 trial which compares brigatinib with crizotinib. Here again, the primary endpoint is PFS, and the secondary endpoint is the overall response rate. Next slide, please. So when you compare these 2 drugs, again, brigatinib had a better PFS when you compare to crizotinib and a better hazard ratio as well. That is, the number of deaths in brigatinib arm were less when you compare it with crizotinib arm. Next slide, please. Now here, patient with brain metastasis in this study were around 30%, and without metastasis were around 70% of the patients. So when we compare the brigatinib, brigatinib had a very good progression-free survival when you compare it to crizotinib for both systemic disease and intracranial disease. Whereas those without brain mets, you can see that there was a progression, an improved progression-free survival with systemic disease. However, it was similar with intracranial disease. Next slide. Now, lorlatinib is another agent against ALK-resistant mutations. So lorlatinib is, again, there are only phase 1 or phase 2 trials which have been done for this drug. This is a very promising drug. The indication for using lorlatinib is if you have already used 2 generations of TKIs and the patient has progressed, then there is role for lorlatinib. Or if you have used the second generation second generation TKI, and if the patient has progressed with second generation TKI, then you can use lorlatinib. Next slide, please. Next slide. So in this trial, as it is a phase 2 trial, so we can just talk about the overall tumor response rate. As you can see that in both the graphs, you can see that the overall response rate was better with lorlatinib than lorlatinib basically. So 83 patients, that is 75% of the patients had brain metastasis at baseline, and it was found that these patients had a very good overall response rate. Next slide, please. The toxicity profile with lorlatinib is hypercholesterolemia, hypertriglyceridemia, edema, peripheral neuropathy. These were seen mainly grade 1 and grade 2 toxicities were seen. Grade 3 toxicities were seen in almost 41 patients. Next slide. Now coming to ROS1 rearrangement. Next slide. So here the standard of care is crizotinib. It is approved for patients with metastatic ROS1 rearrangement positive or ALK fusion positive non-small cell lung cancer. Enterictinib is also been approved, FDA approved, for adult and pediatric patients with locally advanced or metastatic NTRK fusion positive solid tumors and patients with ROS1 positive non-small cell lung cancer. Next slide. So crizotinib is basically acts on multiple receptors. So it is used against ALK mutated non-small cell lung cancer, ROS1 rearrangement, and even some of RET rearrangement non-small cell lung cancer. Even here, using crizotinib has increased the PFS, progression-free survival, in patients with ROS1 rearranged non-small cell lung cancer. Next slide. Entrictinib is again, it has been FDA approved. This is a phase 2 study just showing the progression-free survival, which is around 19 months with entrictinib. Next slide. Next slide. Now coming to BRAF V600E mutation. Next slide. Here, dabrafenib and tremitinib have been used, and the median progression-free survival, which has been seen in both previously treated and untreated patients, around 10 months. Next slide. Here, pyrexia, nausea, diarrhea are a few of the most commonly seen side effects. Next slide. Now coming to new and emerging biomarkers and corresponding targeted therapy in advanced non-small cell lung cancer. Next slide. So first is MET-altered non-small cell lung cancer, that is MET exon 14 skipping mutations. Next slide. Next slide. So crizotinib has been used for MET exon 14 altered non-small cell lung cancer. But when you see the potency, there are better drugs which are available. Next slide. So capmatinib and tepotinib are highly sensitive MET inhibitors, and though they have not been validated with phase 3 trials because MET mutation per se are very less, they have been validated by phase 2 trials, and it has become FDA approved for MET exon 14 skipping mutations. Next slide. Next slide. Next slide. When we talk about the safety profile with both capmatinib and tepotinib, peripheral edema, and most of the patients suffered with peripheral edema with nausea, vomiting, and with in both the arms, it was found that patient had raised creatinine. Next slide. Now, talking about RET fusion positive non-small cell lung cancer. Next slide. Next slide. So here there are two drugs which are again in phase 1, phase 2 trials. One is selpercatinib and brasitinib. Next slide. Selpercatinib, again, because it is in phase 1, phase 2 trial, now the primary endpoint of these trials is maximum tolerable dose and more about safety profile of the drug. Next slide. So here we have seen here in this trial where they have used selpercatinib, they have seen that the overall response rate is around 85% with PFS of 18.4%. Next slide. Again, the number of patients accrued in both these trials are very less. They are less than 10. More studies have to be done. Next slide. In this, you can see that the intracranial METs, this is from both the trials individually. With selpercatinib at baseline, as you can see that there is a single brain MET, and 3 months post-treatment, the response rate is around 91%. And with brasitinib also, it is very promising intracranial response. Next slide. Next slide. Now talking about KRAS mutations. Next slide. Next slide. Okay. So there is a new drug which basically targets the KRAS mutation, that is AMG 5110. It is phase 1 trial, and there is another drug MRTX 849. Again, it is in the phase 1 trial. Next slide. Now coming to NTRK fusion positive non-small cell lung cancer. Next slide. Next slide. There are two FDA approved drugs which act on the NTRK receptors. One is larotrectinib and entrectinib. Next slide. The overall response rate is promising with both these drugs. Again, there are only phase 1 or phase 2 trials which are available with these drugs. Next slide. Now, intracranial response with larotrectinib, as you can see that they have there is partial response in the target lesions in lung, and there is almost near total response, that is in CNS. Next slide. Next slide. Now, this was about targetable mutation. To summarize, the most commonly targeted mutations are EGFR and ALK rearrangement, and the others are less frequently seen. Now, coming to a scenario wherein there are no targetable mutations. Next slide. Here comes the role of immune checkpoint inhibitors. Immune checkpoint inhibitors, there are 4 to 5 drugs which are currently in use. That is nivolumab, pembrolizumab, atalizumab, and durvalumab. Now the trials which relate to nivolumab are usually checkmate trials. They are numbered in different, depending upon when the trial was started. And pembrolizumab, keynote trials are based on pembrolizumab, and atazolizumab are mainly the empower trials. Next slide. Now talking about the role of chemoimmunotherapy in non-squamous, non-small cell lung cancer. Next slide. Coming to keynote trial 189, wherein use of first-line pembrolizumab with chemotherapy versus placebo with chemotherapy in stage 4 non-squamous, non-small cell lung cancer. This is a randomized, double-blind phase 3 study. Now, here, patients who did not have any actionable mutations were accrued either in pembrolizumab with chemotherapy arm or placebo with chemotherapy arm. After 4 cycles, if there was no progression of the disease, patients were kept on maintenance pembrolizumab with pemetrexate until progression or unacceptable toxicity, or they were kept on maintenance therapy with placebo. Tumor proportion score should be less than or equal to 50%. But when you're using it with chemotherapy, or if you're using nivolumab, atezolizumab, you do not have to do PD-L1 expression. So primary endpoint of this study was overall survival and progression-free survival, and secondary endpoint was overall response rate. Next slide. So in this, as you can see that the overall survival was better with the arm receiving pembrolizumab with chemotherapy. This was an intention to treat analysis that was done, and the hazard ratio of this arm was 0.49. This improvement in overall survival was maintained throughout the expression. If PD-L1 was less than 1%, 1 to 49%, and more than or equal to 50%. Throughout all 3 subtypes of PD-L1 expression, this overall survival was maintained. Next slide. Now coming to Empower 150. Empower, it is basically the role of atezolizumab with chemotherapy and bevacizumab. Now, in this trial, there were 3 arms, wherein the first arm was with atezolizumab and chemotherapy. Second arm was with atezolizumab, bevacizumab with chemotherapy, and third arm was with chemotherapy and bevacizumab. The maintenance therapy was in first arm was with atezolizumab, in second arm was with atezolizumab and bevacizumab, and third arm was with bevacizumab. Primary endpoint of this was again PFS and OS. Next slide. So in this, the blue color graph, it represents atezolizumab with chemotherapy and bevacizumab, and the red one, it represents chemotherapy with bevacizumab. So in this, you can see that there is a PFS benefit of the median PFS is around 8.3 months versus 6.8 months. Though the benefit is very small, it is statistically significant. And when talking about the overall survival has improved slightly compared 15 months compared to 20 months, though not statistically significant. Next slide. Now in this forest plot, if you see that the hazard ratio is shifted towards the left side, that is towards the treatment arm, which includes the which favors atezolizumab, carbo with chemotherapy and bevacizumab. I would like to highlight that there are two subtypes which actually benefit more. One is with EGFR ALK positive, and the other one is with liver metastasis. Next slide. So patients with liver metastasis, they had a better median overall survival comparing 9 months with 13 months, and a very good hazard ratio. And patients with EGFR or ALK mutations also had a better median OS with hazard ratio of 0.54. Next slide. Now Empower 130, this compares, this is just this is a phase 3 trial with only 2 arms, wherein chemotherapy with atezolizumab was compared with just chemotherapy, and maintenance therapy was done with atezolizumab and atezolizumab arm, and with pemetrexed in the chemotherapy arm. Crossover was allowed in this trial. Next. When we talk about PFS, the atezolizumab and chemotherapy arm, they had a better progression-free survival when you compare it with just chemotherapy arm. So the hazard ratio is 0.64. And when you talk about the overall survival, again, there is an improvement in overall survival, which is also statistically significant. Next slide. Now coming to first-line chemoimmunotherapy in squamous cell non-small cell lung cancer. Next slide. So first we'll talk about Keynote 407, wherein chemotherapy with pembrolizumab in advanced squamous non-small cell lung cancer was studied. It is a randomized double-blind study with 2 arms. The first arm was with pembrolizumab and chemotherapy, and the second arm was with placebo and chemotherapy. And there was maintenance therapy as well. The primary endpoint was PFS and OS, and secondary endpoint was the overall response rate. Next slide. Here, the progression-free survival was better with the arm containing pembrolizumab with a hazard ratio of 0.56, and it was statistically significant. And this was maintained in all 3 arms, all 3 types of PD-L1 expression. Next slide. Talking about OS, though OS was slightly better with pembrolizumab and chemotherapy arm, it was around 11 months versus 16 months. Next slide. Now coming to immune checkpoint inhibitor combinations. Next slide. So here it is first-line pembrolizumab for advanced non-small cell lung cancer. Once we talk about single-agent pembrolizumab, the PD-L1 expression should be more than or equal to 50%. So patients were randomized either to pembrolizumab arm or chemotherapy arm. Next slide. Here, the pembrolizumab arm had a better PFS and better OS. Next slide. Now, first-line pembrolizumab with chemotherapy, wherein the PD-L1 expression was more than or equal to 1%. So again, patients were randomized into either pembrolizumab arm or chemotherapy arm. Next slide. Here, though there was a modest improvement in progression-free survival and overall survival in PD-L1 expression arm, which was maintained with all types of tumor proportion score. Next slide. Highlighting the slide with the PD-L1 expression between 1 to 49%. So in 1 to 49%, as you can see that the graphs are more or less overlapping. So there was, though FDA has approved use of pembrolizumab in this setting, it is an inferior choice if not added with chemotherapy. So the current recommendation for PD-L1 expression between 1 to 49% is addition of chemotherapy with pembrolizumab. Next slide. Now, this is a forest plot which has almost all the trials with PD-L1 inhibitors and with chemotherapy. So as you can see in the EGFR wild type, you can see that the hazard ratio is less than 1, and it favors the use of PD-L1 inhibitor. Whereas when you see EGFR mutated, you can see that the hazard ratio is crossing 1. That means it is not beneficial to use pembrolizumab in EGFR mutated tumors. Next slide. So Now, management of immunotherapy related adverse events. Next slide. So majority of immune related adverse events are mild to moderate. So it usually responds either by stopping the drug or by using steroids. Severity can be asymptomatic to life threatening, and prompt recognition is crucial. One thing which we have to understand is that the side effects can also occur once the therapy has stopped, once we have stopped the therapy. And it is very important to know what to address these side effects. As you can see in this graph, most of the infusion reaction, GI toxicity and skin toxicity are usually seen in the initial weeks, whereas toxicity, endocrine toxicity, pulmonary and renal are seen to even after treatment. Next slide. So this has already been dealt in detail by all the sirs who have spoken before. Grade 1 is generally requires close monitoring. Don't have to discontinue the drug. Grade 2, you can consider withholding the drug, or you can start on steroids. Grade 3 you have to discontinue the drug and start on IV steroids. And grade 4 leads to permanent discontinuation of the therapy. Next slide. So there are something called the ONS cards. This is a recommendation. Patient receiving immunotherapy should carry such cards, so that if they are going somewhere where, apart from cancer care, if they're receiving any other care for any other ailments, they are supposed to show this card. Next slide. And there is patient checklist as to when to call their physician. So this is basically comes with patient education. Next slide. So summary. Immunotherapy with chemotherapy, it is standard of care, provided there is no actionable targets. Wherever there is actionable targets, targeted therapy has to be given. And once there is progression with a targeted therapy, you can go for second line. And if there is progression with second line, then you can go to immunotherapy. And with that's it. Thank you.
Thank you so much, Dr. Harshita. Now, let us move on to the last topic of the webinar, panel discussion on lung carcinoma. And I would like to invite Dr. Rajiv Jain for moderating the panel discussion. And we have Dr. Pradeep Chandrakar, Dr. Akhilesh Sahu, he's Associate Professor in Department of Radiation Oncology from RCC, Dr. Umesh Divangan, he's Associate Professor in Department of Radiation Oncology RCC, Dr. Rahul Singh, and Dr. Harshita Jain as panelists. Thank you. And
Hello, everyone. Start video. आगे चलो.
the slides you were sharing, or we have to share?
आगे. ठीक. I'll start the panel discussion. Kindly upload the slides, Priyanshi.
Yes, sir.
Yeah. So my first question is for Dr. Rahul is what is the percentage of lung cancer patients are currently getting immunotherapy in your practice?
Right now in our PDs, we have just, recently started this immunotherapy. We are giving pembrolizumab. Today we have given pembrolizumab to a melanoma patient, not in lung cancer. And oral targeted we are giving in lung cancer.
Okay.
But it is with the percentage is very meager.
Okay. Sure. Thank you. Next question, next slide. So then we'll have an opinion from Pradeep Chandaka sir is whether no chemotherapy upfront in non-small cell lung carcinoma or chemoimmunotherapy in all patients of non-small cell lung carcinoma. What is your opinion?
When credibility is no issue, as per the trials we have seen in today's discussion, ideally one should offer chemoimmunotherapy. But in Indian scenario, what we can prefer is no chemotherapy in upfront. We should choose the definitive therapy, especially in early stage. We can go get an option for the surgery, or if surgery is not possible, chemoradiation is ideal.
Next slide. So then we have a case. Then the case is 65-year-old male adenocarcinoma, stage 4, no actionable mutation. Male patient, probably smoker, no actionable mutation. Started with pemetrexed and carboplatin for 6 cycles. Progressed after 4 maintenance pemetrexed. PS1 is 1, no comorbidities, second line treatment of choice. What's your opinion? So first I'll ask Dr. Akhilesh. What's your opinion? What you will do?
Then we go for PDL1 testing.
Okay. Okay. So, ठीक है. You go for PDL1 testing. Okay. And any other opinion from Dr. Umesh?
We can go for the EGFR testing.
But there was no actionable mutation at upfront. There was no mutation. Upfrontly, you tested all the actionable mutation and you didn't got any mutation. Okay. Then any role for best supportive care, Dr. Harshita?
Performance status of the patient is fine.
Okay.
And then
Okay.
there is no issue.
Okay. And Dr. Rahul, any role for chemotherapy? Second line chemotherapy?
We have already given PEM-carbo in adenocarcinoma.
Okay.
Either we can try for immuno plus second line single agent cytotoxic chemo.
Okay. So you are going to test PDL1 in all cases, or you are going to like go away with PDL1 and directly start immunotherapy? Is there anything like
adequate facility in my department, I will definitely go for PDL1.
Next slide. How do you decide? Is there any predictive biomarker, or you need to do a repeat biopsy, any other test, TMB? I'll start with Dr. Pradeep sir. Sir, any predictive biomarker you will decide for immunotherapy?
Repeat biopsy can be an option also, and the TMB scoring. As per the TMB scoring, we can take decisions. Many times, many patients who are initially EGFR positive, later on they becomes negative also. and that may be the reason for progression. So rebiopsy can be an option.
Okay, so like PDL1 is definitely a biomarker which we can do for this patient. And sir, anything regarding like time of rebiopsy, whether patient has recurred that this patient recurred after 4 cycles of maintenance therapy, and suppose a patient get recurs after you say 6 months or 1 year post therapy. So is there any change in your approach, or it's same? You need to do a rebiopsy every time, or you can like change according to the
Complete ignorance is and there is a rule of biopsy.
Otherwise, if there is later recurrence, we can re-challenge the patient with the same therapy we have planned earlier. Our best option is immunotherapy in this case. How
How do you select an initial treatment in non-small cell lung carcinoma? Histology, lack of actionable mutation, chemoimmunotherapy, level of PDL1 expression, immunotherapy alone, chemotherapy alone. So first I'll start with Dr. Umesh. What is the initial treatment in non-small cell carcinoma according to histopathology?
if there is a form of a document, we can go for fractal capture if there is a demo document, they can take the cover
In non-small cell NSCLC, are you going to go for pemetrexed every time, or you are going to do something?
in the demo document.
Yeah, yeah. Okay. Like you need to do a mutation test to find out the actionable mutation, and if you don't have any actionable mutation, you may go for pemetrexed. Then what are the actionable mutation, Dr. Harshita?
It is EGFR
Okay,
and ELT. ROS1
okay,
beta 600B
okay,
mutation.
okay. I think BRAF you have told, huh? Then ERBB, NDR. Chemoimmunotherapy, Dr. Akhilesh. What are the chemoimmunotherapy you think is good? What are the immunotherapy agents you may add to your chemotherapy?
In first line setting, also relating squamous cell carcinoma,
Okay,
in family, along with the invasion of creative benefits of target,
okay,
in mind benefits, or in non-small cell carcinoma, along with the invasion of creative benefits of target.
like you can also enumerate us more IO agents, if you can add, like other than pembrolizumab.
We have like atezolizumab
Okay,
or ipilimumab and
okay,
nivolumab combination.
okay. And one more is durvalumab. Okay. And now, Dr. Rahul, what is the level of PDL1 expression you will go for? Like, how will you assess PDL1 report?
In already established PDL1 more than 1%, you can go for PDL1 inhibitor.
Okay,
I will like to go with if it is more than 1%, I would like to go with pembrolizumab along with chemotherapy. Depending upon the histopathology.
okay. And sir, Pradeep sir, what is your idea about immunotherapy alone?
Immunotherapy alone shouldn't be chosen because immunotherapy plus chemotherapy, it is effective in all groups. And in first initial 6 months, you will see all the side effects of the immunotherapy. There may be a pseudo progression, or pseudo progression, or there may be no response that can't be assessed. So ideal may be not immunotherapy alone. We can choose chemoimmunotherapy.
There needs some subgroup of patient where you may like they may not, you think that they may not tolerate chemotherapy, you may do it for IO alone or IO plus IO kind of thing. Yeah. And any patient for chemotherapy alone, Dr. Umesh? If you do a PDL1 PDL1 test and patient do not had any PDL scoring less than 1, you know, so you can you may not use immunotherapy to that patient as well. Next slide. The difference between approved agent required for PDL1 expression is only pembrolizumab. So only one drug which has a better assay related to PDL1 is pembrolizumab. Predictive nature of PDL1 assay is pembrolizumab is most well validated. Nivolumab had a similar assay, but most validated and related to PDL1 score is pembrolizumab. First line approval only pembrolizumab alone if more than 50% PDL1 expression. If your patient has more than 50% expression, pembrolizumab alone can be used or in combination with carboplatin pemetrexed for non-squamous cell histopathology. Schedule is atezolizumab and pembrolizumab every 3 weekly versus nivolumab every 2 weekly. Atezolizumab and pembrolizumab you can give it 3 weekly and nivolumab every 2 weekly. Next is price. All are very high. The actual cost is not entirely transparent and it's actually very high cost, but very high burden to the health system. Next slide. What is monitoring of adverse event related to immunotherapy? What's your experience? How frequently you monitor various lab parameters? So I'll start with
lab parameters, we can see any change in the LFT, RFT, all these things. And initially, it is very difficult to monitor immune response in initial 6 months. And there is a different response criteria is used for this. It is not similar to the resist criteria we use. And initially, you will see only increase in the size. So it is very difficult to monitor.
next slide. Case 2. It's a 50-year-old smoker, extensive stage small cell carcinoma lung. PS score is 1. Treatment options. So what are the treatment options, Dr. Akhilesh?
Performance status 1, sir, first
Extensive stage. Will you go with chemotherapy or chemoimmunotherapy? What are you going to? Like we have studied today.
Sir, patients affordability is
If patient is highly affordable, we are talking. Okay. Dr. Umesh, what are the upfront chemoimmunotherapy which are approved in SCLC, ESSCLC? Immunotherapy. What are the immunotherapies which are approved in FDA approved in SCLC, extensive stage SCLC? There are. We have only two agents which are approved. One is atezolizumab and second is durvalumab, which are FDA approved. You can give pembrolizumab, but the approval for this particular indication is this two drugs till date. You obviously they are all working on the same target, so you can interchange it, but approval has come to two particular two agents. Okay. Next slide. Evaluating role of multi-drug therapy in early EGFR mutant NCLC clinical case. There is a patient, male, 65-year-old, never smoked, persistent cough, hemoptysis, dyspnea, loss of appetite, no history of cardiac abnormality. Chest X-ray 45 mm, diameter tumor 4.5 centimeter, and 10 mm right hilar lymph node, 15 mm mediastinal lymph node. No brain metastasis. EBUS biopsy done. That's come to be adenocarcinoma, TTF1 positive and CK7 positive. PFT, it is good PFT. FEV1 is more than 40% and TLCO is more than 40. Peacock performance is 1. Stage 3 non-small cell lung carcinoma, T2B and 2M0. Biomarkers done is PDL1 score is more than 65%. NGSX panel was done. EGFR was exon 19 deletion, TP53 mutation, low TMP, and MSS score. So, what the treatment is? Surgical resection with curative intent, post-surgery right upper lobectomy, and lymph node dissection. And resection margins were negative, PT2B and N2 monocyte. Okay, so what are the adjuvant treatment options? I'll start with Dr. Rahul.
It is P2B and 2. And biomarkers PDL1 is more than 65%. GFR exon 19 deletion is there. TP53 19 deletion is there. We can go for osimertinib. TP53 mutation is there. PDL1 we can go for immunotherapy as well. Adjuvant therapy. So adjuvant therapy post surgery, right upper lobectomy, lymph node dissection has been done. Margin is negative. So it is early stage, it is PT2B and 2 here. We can go, why don't we go for radiation in this patient? Post surgery. It is post surgery. It is post surgery. Okay. Post surgery. We can go for EGFR target therapy along with adjuvant cytotoxic.
Any combination you would like to use?
Here I will like go for chemotherapy for cycle, at least 4 cycle that was given the trial, followed by EGFR targeted osimertinib.
Okay. Sir,
we can keep this for later on. PDL1 expressions more than 65%.
Okay. So you want to give immunotherapy right now, or you can, keep it for
time to progression will be great if we will combine both of this. Acha. We cannot give PDL1 if there is driver mutation. It will be least effective. Less effective.
Good drug is available with us. There is osimertinib, so we can go ahead with that.
So PDL1 for positive.
Once there is progression, after that we can think for immunotherapy.
It is already written, sir. Driver mutation hoga to
then there is a question like, will you add osimertinib to chemotherapy, or you will give osimertinib alone?
I will go for osimertinib alone because already actionable target is there.
There is a data in that osimertinib trial where it says that if you add osimertinib to chemotherapy, the overall result is the progression-free survival is better in osimertinib plus chemotherapy versus chemotherapy alone in this particular setting. But with added toxicities, because toxicities are going to add.
Positive. So there comes the therapy. What I think, उसमें chemotherapy adjuvant देना चाहिए और उसके बाद फिर what positive.
We'll go for an adjuvant osimertinib for 1 year. Next slide. Exploring second line and novel therapy option. SCLC patient case study. A 62-year-old smoker, 2 pack cigarette per day, 30 years, quit 7 years ago. Past medical history: hypertension, ED with visited because disoriented, not eating, 15 kg weight loss, 15 pounds weight loss. CT finding 4.3 into 3.2 into 4.6 centimeter right lung mass with extensive lymphadenopathy. Peacock performance score 1. Lab test sodium 126, potassium 4.6, and bilirubin bit raised, but almost everything in control. What next, Dr. Umesh? This is small cell lung carcinoma. We are discussing about small cell lung carcinoma. And then you may start with your treatment. What are the treatment you want to give? Do you want to add some investigation to this particular investigation set, Dr. Akhilesh, Dr. Umesh? PET scan or anything else? If you can see the symptoms. Patient has presented with this orientation. So will you consider an MRI frame? Next slide. Patient completed 4 cycles of chemoimmunotherapy, atezolizumab and carboplatin etoposide, and was restaged with PET CT, which showed stable disease and maintenance atezolizumab every 21 days. Next slide. 5 months into treatment, patient is on maintenance therapy. Now patient called the clinic complaining increasing shortness of breath. So CT confirmed that there is a recurrence. What next? Sir. Dr. Harshita, what next? How, like this is a case. He received atezolizumab plus chemotherapy, progressed. Next. It is the best treatment for disease recurrence in this patient. We studied. Next. So, if this patient has a relapse less than 6 months, or this patient has a relapse more than 6 months. If less than 6 months, start oral topotecan or lurbinectine or clinical trials. Because this do not have very good results in phase 3 results till now. Or if relapse more than 6 months, go for our original regimen. Next slide.
Sir, it is done. Okay. Now I would like to invite Dr. Nigam for giving the vote of thanks.
Hello?
Yes, sir.
Yes, sir. Thank you, Dr. Vivek sir. Vivek sir, is he here or not?
No, sir.
Okay, don't worry. So, thank you, Pradeep. Thank you, Adarth. It is very good and informative lecture delivered by you. But in short, I am saying that कि आजकल जो लंग कैंसर बढ़ा है उसका मेन कारण जो हम लोगों ने उसके विषय में भी ध्यान देना होगा। धूल, धूप, धुआं, तीनों चीजें हमारे समाज में बराबर बढ़ती जा रही हैं। एक अवेयरनेस प्रोग्राम इस पे भी चलाना चाहिए जो टेक होम मैसेज के लिए मुझे बोला गया है। यस, इट इज गुड, वेरी इंफॉर्मेटिव ट्रीटमेंट मैनेजमेंट डिलीवर्ड बाय यू इन रिसेंट केसेस, बट every treatment should be according to area, patient and the society. I am seeing so many patients which were referred from Tata, Bombay, Delhi. They are coming with the so costly, so fantasy drugs, which is not able to purchase, not able to tolerate, not able to pursue in future in whole 6-month life, 8-month life. So we should be so taking concern about all these things. So this is should be take home message कि according to treatment, according to society, according to patient stage, histology, everything, we should decide the treatment. Not only कि पेशेंट आया है हमको ट्रीट करना है, क्योंकि हम लोग रिमोट एरिया में बैठे हुए हैं, वी आर नॉट इन मेट्रो सिटीज। हम लोग इतना न तो बहुत कॉस्टली पेशेंट को एडवाइस कर सकते हैं, ना थोड़ा सा इतना सब कुछ बता सकते हैं, हमको उनकी सोशल लाइफ, उनकी फैमिली लाइफ, उनकी उस पर भी थोड़ा ध्यान देना पड़ेगा, स्पेशली स्टेज 3 स्टेज 4 पेशेंट और मेटास्टेटिक पेशेंट्स। उनके कंडक्ट, उनके बिहेवियर को ध्यान में रखते हुए हम लोग अगर ट्रीटमेंट एडवाइस करें और थोड़ा सोसाइटी को अवेयर करें कि पहली बात तो कैंसर हो ही ना, यदि हो तो कैसे उसको परस्यू करें, क्योंकि सभी पेशेंट बड़े बड़े शहर नहीं जा पाते हैं, अल्टीमेटली हमें ही डिसाइड करना है। हमने ये भी देखा कि बायोप्सी होती है, बायोप्सी के लिए क्या क्या करना चाहिए, न सिर्फ लिख नहीं देना चाहिए, जो है उसी के अनुसार ट्रीटमेंट दें। इन्वेस्टिगेशन भी अकॉर्डिंग टू पेशेंट ही एडवाइस किया जाए। तो ये हमारा टेक होम मैसेज आज का होना चाहिए कि इतनी अच्छी हमारा जो सिंपोजियम डॉक्टर विवेक चौधरी, प्रदीप और तुम सबके द्वारा किया गया, तो कम से कम अकॉर्डिंग टू पेशेंट हम सब अगर करेंगे तो सोसाइटी कुछ ना कुछ दे पाएंगे। थैंक यू फ्रेंसी, थैंक यू फ्रेंड्स का भी बहुत बहुत धन्यवाद।
Thank you, sir.
Thank you, sir. Thank you, sir.